lower urinary tract symptoms. And we will be starting off from some basic concepts on physiology and neuroanatomy of the urinary tract. We are going to then talk about that the site of lesion, its impact of various neurological conditions related to the lower urinary tract, followed by ABC of urodynamics. So some of the very basic things about urodynamics. This will be followed by overactive bladder and what can be done in the management. And then there will be an interesting session on BPH and the lower urinary tract symptoms. It will be a case-based discussion led by a group from Birmingham by Anand Thanasekharan and his colleagues, including Fahad Khan and Tariq Sami. So thank you very much for joining. I would invite now our senior resident, Dr. Ahmed Bashir, to talk about physiology of micturition and some neuroanatomical principles. Dr. Ahmed.
Right. Thank you, Dr. Hamad. Assalamu alaikum, everyone. Dr. Hamad has already told you, my name is Dr. Ahmed Bashir, and I will be going over physiology of micturition. Now, I'm in my senior year of residency, urology, and if I was to see this as the first slide in a presentation that is actually based on physiology, and I see sympathetic nervous system, parasympathetic nervous system, somatic nervous system, cortex, periaqueductal gay, pontine micturition center, end organ, detrusor, sphincter, etc. I would probably lose interest right here and then, and think this is probably something that I've long forgotten, and I will not be able to grasp much out of this. So I have done my best, and okay, yeah. For this matter, I would want the attention of the trainees mostly, without any offense to anyone. I am probably top of the list, and maybe the faculty can refresh some of the basic concepts as well. I've tried to keep it very simple because the latter half is probably going to get complicated. Right. This is a diagram that most of us have probably seen wherever we've looked up bladder micturition and receptors involved, because this was from the Nature, and it's probably the most used diagram. Now, on this diagram, the three peripheral nerves which are involved, namely the parasympathetic pathways, the sympathetic pathways, as well as the somatic or pudendal nerve pathway are involved. Now, all that we need to really remember here, from because these are some nitty-gritties that we do come across MCQs once in a while, is that the level of the parasympathetic pathways arise from the sacral spinal cord, S2 to S4. Absolutely need to know this. There is a sacral parasympathetic nucleus, very easy to remember. The nerve involved is the pelvic nerve. The neurotransmitter, as you can see from the diagram, is acetylcholine, and the receptors that it acts on preganglionically are nicotinic, but on the bladder are muscarinic. That is it. You probably know all of this. Now, the next, the nerve below it, the sympathetic pathway, the levels are T10 to L2. The nucleus involved is the mediolateral nuclei. There are two nerves actually, hypogastric nerve predominantly, but sympathetics also travel through the pelvic nerve. So the pelvic nerve thereby conducts both sympathetic and parasympathetic pathways, or just like the previous parasympathetic pathways, all pre-ganglionic neurotransmission is mediated via acetylcholine. Post-ganglionic is adrenergic, so noradrenaline, and primarily the role was in keeping the tone of the outlet, where you see the urethra and the alpha-1 receptors, but later on it was found that beta-3 receptors have quite a role, and hence the role of beta-3 adrenergic agonists that we use, namely mirabegron. And the pre-ganglionic receptors, as always, is nicotinic, and post-ganglionic, as we said, is adrenergic. And the third and the last player of the peripheral nervous system is the somatics, which also arise from the same level. The onus nucleus is involved, and the nerve is pudendal. And for the AQ trainees who appeared in the exam, in the internal exam today, the nerve involved for the function of the external urethral sphincter is the pudendal nerve. Neurotransmitter again acetylcholine, preganglionic again nicotinic, and postganglionic nicotinic. So this is it for all that is happening at the level of the bladder. Now this is the simple part of it, and most of us already knew all of this. Now comes the role of the afferent fibers. Now afferent fibers are basically the fibers which are taking the input from the bladder to the higher up authorities, be it the spinal cord or be it the central nervous system. The most important of these fibers are the A delta fibers. Now A delta fibers are always active. You and I and everyone else with a normal bladder are sitting with some influx of urine coming into the bladder, and the A delta fibers are responding to this passive dilation, passive distension of the bladder, and or in other words, bladder filling. Now, these are myelinated fibers and they have a low activation threshold, so they tend to start firing as soon as there is some filling of the bladder. And then they come the C fibers. Now, the C fibers are involved in special situations. They respond to chemical irritation and cold, and they're usually unmyelinated and they have a high threshold, high activation thresholds, also referred to as silent fibers. However, when we're talking about chemical irritation, when we're talking about cold, when we see our patients getting bladder spasms, these are the fibers which are firing at that time. Now, from these afferent fibers, just as I said, there is continuous input to higher up authorities, the periaqueductal gray matter and the pontine micturition center in the brain stem. And we will see just in a minute what their role is. Now, primarily, if you just think about it, there's just two things happening. The bladder is either filling or the bladder is either emptying, right? So bladder filling or storage, how does that happen? Let's just take a look. Now, and keep in mind, bear in mind, the functions that we were talking about, if you remember the first diagram, there's the detrusor and there is the outlet. This is where the antagonism comes. When the filling is taking place, the detrusor obviously has to relax, but at the same time, it is as important for the outflow to be contracted, and hence the antagonism between the parasympathetic and the sympathetic pathways. So this antagonism, now it is beautiful because we do not have medications that can target both of these pathways at the same time. However, the innate or the built-in mechanism that we have in the body, such as the PMC and the periaqueductal gray that we just talked about, control at the same time these descending pathways. Let's see how. Now, bladder filling, we talked about the activation of A delta fibers, and these fibers then take input to the sympathetic fibers. What did we say? The level of the lumbar cord. What the sympathetic fibers do, in addition to their effect on the bladder, they also have an inhibitory effect on the parasympathetic nervous system. So parasympathetic, remember P for parasympathetic, P for peeing. We don't want that to happen when we are storing or when we're filling. So the sympathetic fibers, they're going to decrease the parasympathetic input, and they're going to send noradrenergic input to the beta 3, thereby the agonist effect of relaxation. And as we said, it is extremely important for the outlet to be contracted at the level of the urethra. And all of this, what it essentially results in is storage of urine and inhibition of micturition. This very simplified diagram is what is referred to as the vesico, starting from the bladder, spinal taking place in the lumbar cord, vesicle ending up back in the bladder, reflex. I hope that is clear. So now with bladder filling, I mean, there has to be a point when it stops, right? We cannot go on storing urine forever. So there has to be something that is regulating till what time is this acceptable, and at what time does this have to stop, and at what time do we have to shift to bladder emptying, also known as micturition. Now, we've already talked about the afferent activity to higher spinal cord and brain, which is basically the periaqueductal gray and the pontine micturition center in the brain stem. These centers are what have control over the descending parasympathetic pathways. But it's not that simple. They are also getting input from the cortex and hypothalamus. And this is where our learned behaviors come into play. Our emotions come into play. How we know where we have to avoid, the appropriateness of micturition. This is why we have learned all our lives to not just go pee in the middle of a room. So this all is actually linked to all of this system in the periaqueductal gray and the pontine micturition center in the brainstem, which control the descending pathways. So now in the descending pathways, obviously because they want to pee, so they're going to activate the P or the parasympathetic, and the parasympathetic activity through its action on the detrusor through the receptors that we just saw are eventually going to lead to micturition. So at the same time, this is how they work. And this is why the pontine micturition center is also referred to as the switch, the on and off switch. Now we don't want to pee. That's fairly simple. You decrease your input to the descending pathways, or you inhibit the descending pathways, and then thereby decreasing the parasympathetic activity and letting sympathetic activity take precedence. So this is fairly what micturition is all about. And I hope this was very clear. I've kept it very short because a better understanding of it can arise from clinical correlates. And we are thankful that I'm being followed by Dr. Nazim, who is going to take over and talk about all that can go wrong, unfortunately, with all of this circuitry. So over to Dr. Nazim. Thank you very much for your time. And if you people have any questions, you can mention them on the chat box, but I'm sure they will probably be addressed somewhere in Dr. Nazim's talk. So thank you everyone once again for your time, and over to Dr.
Thank you, Ahmed. I think this is a very short, brief, and lucid presentation. These are essentially very important concepts to understand the lower urinary tract symptoms, the dynamics between somatic and the autonomic nervous system, and the various components of autonomic nervous system, i.e. the parasympathetic interplay between the parasympathetic and the sympathetic nervous system, not only for the working of the lower urinary tract, but also for erectile function. So we can have lesions anywhere from the peripheral nerves to central nervous system, and in the central nervous system, the spinal cord, as well as going all the way up to the brain. In order to understand the site of lesion and its potential impact on the lower urinary tract, Dr. Nazim, who's an associate professor at Khan University, is going to talk about the level of lesion and impact on urinary tract. So remember, these two are very important presentations, after which we're going to move on to the clinical aspects, starting from urodynamics to overactive bladder and BPH in male looks. So over to you, Nazim.
Thank you very much, Dr. Hamad. So I'm glad and I'm very thankful to Dr. Ahmed. He has made a very good presentation, a very simple but very good presentation to clear the concepts. Right, so there is some technical issue. Right, thank you. So we are going to talk about the pathophysiology of neurogenic bladders. So lower urinary tract, which includes urinary bladder, urethra, and muscular urinary sphincter, is complex, and it requires intact nervous signal conduction and modulation at the peripheral level. So this includes the coordination between the nerves of pelvic region as well as neuronal centers in spinal cord and the brain. And this complex nervous network permits a smooth switching between the two principal but opposing functions of the lower urinary tract, which is the storage of urine in the bladder at low pressure and periodic voluntary total emptying of the bladder during voiding. So this is being explained by Dr. Ahmed, but I'm just going to give you a brief neuroanatomy. So he talked about the cortex. So cortex mediates the sensation and voluntary initiation of micturition. The pontine micturition center or periaqueductal gray, it mediates the coordination between the bladder and sphincter and helps to complete the voiding. And the spinal reflexes are generated at the sacral micturition center. And this is basically, this mediates the reflex bladder contraction, what he called as vesicospinal vesical reflex. Again, in the sacral part of the spinal cord lies the Onuf's nucleus, which controls the pudendal nerve and causes the guarding reflex. The sympathetic nervous system, starting from T10 level of the spinal cord to L2, mediates the receptive relaxation and inhibits the bladder contraction during the filling phase of the bladder. So I will skip through this slide. This is basically about the switching between the storage and as well as the voiding function of the bladder with the role of cortex and the pontine micturition center that Dr. Ahmed has already covered. The disturbances in nervous system leads to neurourological symptoms depending upon the extent of the lesion as well as its location. The patients with neurourological conditions can be symptomatic or asymptomatic and can develop a variety of complications, including urinary incontinence, recurrent UTIs, hydronephrosis, and eventually even renal failure. And this all is accompanied by negative impact on quality of life because of incontinence and UTIs, etc., and bothersome lower urinary tract symptoms. However, it is important to note that symptoms and long-term complications, they do not correlate. And it is important to identify patients with neurological symptoms. A neuropathic bladder is not just a dysfunctional normal bladder because the bladder is normal, but the control systems are impaired or absent, leading to impaired or loss of voluntary voiding, and again the continence can be lost or impaired. I will just quickly go through the 2021 EAU guidelines, recommendations for history, physical examination, and some of the level of evidence for suspected neurourological conditions. So they say that during the history taking, one must identify and ask for the specific urinary symptoms, such as what was the onset, what about the bladder sensation, whether the initiation of micturition is normal, precipitate, or reflex, is it accompanied by enuresis, and the other lower urinary tract symptoms questions, including the incontinence and mode and type of voiding. Along with that, the past history is important, particularly the milestones, the heredity of familial risk factors, obstetric history, particularly in females, obviously in females, the history of diabetes mellitus and accompanying diseases like history of CVA in the past, syphilis, encephalitis, or multiple sclerosis, any history of previous operations or accidents, history of medications, and history of alcohol consumption, smoking, etc. Apart from the urological history, because the neurological conditions impact the sexual system, the bowel, as well as other neurological systems. So this history is also important, particularly whether the patient has sensation in the genital area in the males about the erection, the orgasm, and whether the ejaculation is present, whether it is retrograde or there is an ejaculation, and in female, the lack of orgasm and dyspareunia. With regard to bowel history, whether the patient feels the desire to defecate, what about the rectal sensation, and what about the frequency of bowel movements, and is there any history of fecal incontinence? And about the neurological history, whether there is any acquired or congenital neurological condition, what about the patient's cognitive function, comprehension, and mental status, and what about the neurological, somatic, and sensory neurological conditions, and about the patient's dexterity and mobility. The physical exams must include the examination of reflexes pertinent to lumbosacral spinal cord levels, such as the bulbocavernous reflex, the perianal anal reflex, the anal tone, the knee jerk, the knee and the ankle reflexes, and prostate must be palpated because that can complicate a benign enlarged prostate can complicate the matter further, and whether there is any prolapse of pelvic organs. So the recommendation of EU guideline is that one must pay attention to existence of alarming signs such as pain, infection, hematuria, and fever, which warrant further diagnosis. And apart from history and physical examination, a routine urinalysis, blood chemistry, voiding diary, measurement of post-void residual volume and UFM, the quantification of incontinence, and urinary tract imaging is of utmost importance. Urodynamic investigation is the only method that can objectively assess the dysfunction of lower urinary tract. So now moving on to the localization of the lesion and the impact on the urinary system. So again, the knowledge of neuroanatomy and neurophysiology helps to predict which type of lower urinary tract symptom abnormality may arise from the lesion. And this lower urinary tract dysfunction, the vesico-sphincteric pattern, is dictated by a number of the factors. This is very important to remember, that the level of injury is very important, be it in the brain area, in the brain stem area, in the spinal cord, at which cord level, or at the level of peripheral nerves. What is the severity of injury? Is it complete? Is it partial? Is it one-time injury, or is it one-time lesion, or is it gradually progressing over the period of time? What is the etiology? Is it reversible or is it destructive? Is there any previous history of concomitant neurological conditions or urological conditions such as BPH or vaginal prolapse, and how the symptoms have progressed over the period of time? So this is a diagram where you can see, and the lesions can be classified at 4 levels. So this is the area of pontine micturition center in the pons. So the lesions can be classified as suprapontine lesion, including the areas of forebrain and midbrain. The lesions can lie between the pontine micturition center or at pontine micturition center and above the sacral part of the spinal cord, which is called as suprasacral lesions. Lesion can lie at the level of sacral spinal cord, and lesion can lie at the level of cauda equina or peripheral nerve. And all these have varying signs and varying impact on the lower tract. So this is a diagram, a schematic representation of the previous one, but it is important to realize on over here you can see the spinal cord, and over here you can see the level of the vertebra. So in adults, the vertebral level and spinal cord level do not lie adjacent. You can see that the thoracic spinal cord finishes somewhere at the level of T7, T8 thoracic vertebra. And similarly, the spinal cord ends at the level of L1 lumbar vertebra, beneath which lies the cauda equina. So let's take an example. So if a lesion lies at this level of the thorax, at this level of the vertebra, that is, if there is, for example, a T12 L1 prolapse of intervertebral disc, then it will not affect the T12 or L1 level of the spinal cord. Rather, it will affect the sacral part of the spinal cord. So now this is the next few slides will talk about the location of lesion with associated neurogenic lower urinary tract symptom, lower urinary tract dysfunction, and what symptoms and signs the patient would exhibit, and few examples of those neurological lesions. So suprapontine lesion is a neurological lesion above the level of the pons, and once there is a lesion in the above the level of the pons, so the inhibition of pontine micturition center by cortex is lost. So there will be a reflex detrusor contraction. There will be impaired cerebral regulation and central inhibition. But as the pontine micturition switch is intact, therefore there is synergistic widening, and there is a synergy between the bladder and sphincter. The bladder sensations are often preserved. The symptoms and signs that patients have, they have urinary frequency, urgency, urge urinary incontinence, reduced awareness of bladder fullness. Very less often they have some of the voiding symptoms, and deterioration of upper urinary tract is uncommon because there is no detrusor sphincter dyssynergia. Example includes cerebrovascular accidents, brain tumors, Parkinson's disease, and multi-system atrophy. So a lesion at the level of the cortex will lead to the patient not knowing whether his bladder is full or not, and whether it is a right time and place to void. And the impact on the pontine micturition center is lost. So in a suprasacral spinal cord lesion, the lesion lies in the suprasacral part of the spine or at the level of the pons. What abnormality will you find on urodynamic studies as well as in the bladder will be detrusor overactivity and incontinence with or without detrusor sphincter dyssynergia. There is often significant post-void residual volume, and these bladders are not safe because they are high pressure bladder. Patients usually exhibit both storage and voiding symptoms, and because of the high pressure bladder and DSD with raised PVR, there is significant threat not only to the bladder but to the upper urinary tract. And with subsequent repeated UTI and progressive bladder and upper tract deterioration, patients may eventually end up with the with end-stage kidney disease. Examples of this condition include traumatic spinal cord injuries, multiple sclerosis, the myelodysplasia such as meningomyelocele involving the thoracolumbar level of the cord, and myelitis of different etiology. Now, the injury or lesion at the level of sacral spinal cord can involve both the detrusor or parasympathetic nucleus as well as the onus nucleus, or it can predominantly affect either of these nucleus. In cases whenever there is injury or lesion to the detrusor nucleus, this is called as type A, mixed type A sacral spinal cord lesion. Because there is no parasympathetic drive, there will be detrusor areflexia and the detrusor will be acontractile. The sphincteric function is intact because of the intact onus nucleus. In mixed type B, which is less common as compared to mixed type A, the onus nucleus is disturbed, so there will be impaired sphincteric activity. However, because of the uninhibited detrusor nucleus, the bladder will be spastic. Patients will exhibit signs and symptoms of stress urinary incontinence with poor flow, Valsalva voiding with interrupted flow, and in cases of type A, there will be overflow incontinence. Conditions that lead to sacral spinal cord lesions include traumatic spinal cord lesions at the level of sacral cord, lumbosacral myelodysplasias, and sacral malformations. The infrasacral lesions include neurological lesions that affect the quadrata equina or peripheral nerves. Again, the bladder will be acontractile and it might accompany the stress urinary incontinence. There will be large capacity bladder with overflow incontinence. Example includes peripheral nerve conditions such as poorly controlled diabetes mellitus leading to diabetic cystopathy, and extensive pelvic trauma as well as radical pelvic surgery, radical pelvic gynecological, urological, or colorectal surgeries that can lead to infrasacral disturbance and urological symptoms. Mixed neuronal lesions include lesions of the neuronal pathways at the different levels of central nervous system. And because of involvement of the different levels, maybe such as mixed neuronal lesions are common in multiple sclerosis, which can affect the brain, the peripheral nerves, and the spinal cord. So the picture will vary, and these are the complex lower and lead to complex lower urinary tract dysfunction. And these conditions are often progressive, and in association with other conditions like diabetes and BPH, the signs and symptoms often progress and varies with the period of time. So this is the summary. So suprapontine lesion has patients with suprapontine lesions have predominantly storage symptoms. Ultrasound shows insignificant PVR volume, and urodynamics shows detrusor overactivity. This is a diagram which shows that in the suprapontine lesion, the bladder is overactive and sphincter is normoactive. In the suprasacral spinal cord lesions, what happens that because the coordination is lost, so patient has both storage as well as voiding symptom, there is increased PVR. Urodynamic studies shows DSD as well as detrusor overactivity. So this shows that both sphincter as well as the detrusor are overactive. At the sacral and infrasacral level lesion, there will be predominantly voiding symptom because of areflexic bladder. Post-void residual volume will be raised on ultrasound, and urodynamic study will show hypocontractile or acontractile bladder. Now, moving on to the specific entities and their impact on the lower urinary tract. So spinal shock is a condition which is an initial temporary phase following an acute neurological insult, such as cerebrovascular accident or spinal cord injury. Immediately after this insult, there is loss of sensory, motor, and reflex activity below the level of injury, and there is temporary, complete, painless urinary retention, along with bowel and sexual conditions. So the transition is that within the days, the bowel sound starts to appear. In days to weeks, somatic reflexes appear, and there is a spasticity in the muscles. Within weeks to months, the bladder becomes reflexic. The bowel also show reflex activity and erections start. In months to year, if the injury is incomplete, the patient may gain voluntary movement and urethral sphincteric control. The ejaculatory functions are the ones which are the last one to recover. Another condition is autonomic dysreflexia, which usually accompanies injury to the thoracic or cervical spine, upper thoracic or cervical spine above the level of T6. What happens in this condition, which is a potential medical emergency, whenever there is a stimulus in the field of distribution of autonomic sympathetic nucleus, there is an unregulated sympathetic function below the lesion, and there is a compensatory autonomic response characterized by hypertension, bradycardia, piloerection, severe headache, and flushing above the level of the lesion, with pallor below the level of the lesion. And sometimes it leads to convulsion and hypertensive crisis. Treatment includes removal of the cause, moving the patient to the upright position. If the catheter is in place, it is blocked or leads to UTI, you need to change the catheter. You need to bring the blood pressure down by GTN spray, sublingual captopril, or sometimes IV, use of IV labetalol. Now, a spinal cord, whenever a patient has a spinal cord injury, so there are certain description that needs to be done, or that needs to be described with that spinal cord injury. So you need to know the last segment which has a near normal function. So for example, if the injury is at the level of thoracic T6 spine, it may involve T6 and beyond, maybe up to T8, maybe up to lumbar level as well. But you must know the last normal functioning segment of the thoracic, of the spinal cord at that level. Whether the injury is complete or incomplete. If it is incomplete, what is the pattern and what is the severity? And what is the type of paralysis? Is it spastic or is it flaccid? So whenever there is spinal cord injury, there is spinal shock characterized by areflexes, reflexic bowel and bladder, and flaccid paralysis. If it involves a long segment of the cord, including the sacral as well as lower down segment, there will be flaccid paralysis and areflexic bowel and bladder, which will continue for the rest of the period. If it is incomplete injury, or if it is limited to a small area of the spine with intact sacral and infrasacral portion of the cord, then there might be a spastic paralysis and bladder and bowel will be reflex. Now, talking about the effect of length of the lesion. So you can see that in both of the diagram, the injury or lesion lies in the upper thoracic level. But here you can see the injury is confined only to a small portion of the thoracic spine. While in the right side of the diagram, you can see the injury involves much more thoracic portion of the cord as compared to the left one. So this is the example of certain conditions, the congenital conditions, acquired conditions, and the conditions which progress over the period of time. So the brain conditions which can have neuropathic bladder include, the congenital conditions include cerebral palsy, acquired conditions include stroke, head injury, and the progressive conditions might include multiple sclerosis, Parkinson's disease, and dementias. For the suprasacral spinal cord lesions, the common congenital conditions include neural tube defects such as meningomyelocele. Acquired conditions include spinal cord injuries, and progressive conditions include cervical and lumbar spondylosis, multiple sclerosis. For the sacral spinal cord and peripheral nerve conditions, again, the congenital conditions that involve include meningomyelocele, sacral agenesis, and anorectal anomalies. Acquired conditions include correct venous syndrome, spinal cord injury, and peripheral nerve injury from radical pelvic surgeries. And progressive conditions might include peripheral neuropathy because of the acquired conditions. I will just briefly touch upon 4 or 5 conditions which can have impact on the lower urinary tract system. Dementia is a condition, debilitating condition, which is characterized by atrophy and loss of both gray and white matter. It predominantly affects the frontal lobe, which mediates the task related to memory and mentation. So most of these patients with dementia have urinary incontinence because of both of these factors. First, there is loss of cortical control over pontine micturition center. So patient lose the awareness of desire to voluntary void with having rectusal overactivity. We all know that Parkinson's disease is a neurodegenerative disorder because of the degeneration of neurons in the substantia nigra. And this disease is characterized by bradykinesia, rigidity, and tremors. Majority of patients present with overactive bladder symptoms, but they might have detrusor underactivity, DSD, and bladder outflow obstruction. Multisystem atrophy is also known as Child-Drager syndrome. It's a progressive neurodegenerative disease of unknown origin. It is characterized by late diagnosis, and patients generally have symptoms for years, urological and neurological symptoms for years before the diagnosis is being made. Patients exhibit signs of Parkinson's disease along with cerebellar, autonomic, and pyramidal dysfunction, and lower urinary tract symptoms are much more bothersome. It leads to decreased bladder compliance, detrusor overactivity, and patients have difficulty in initiating and maintaining the voiding. Multiple sclerosis is a demyelinating disease of central nervous system, which is characterized by relapsing, remitting, and progressive course. And it involves optic nerve, pyramidal tract, abnormality leading to ataxia, poor bowel function, lower urinary tract symptom, lower urinary tract dysfunction, and sexual dysfunction. And signs and symptoms vary among the patients because the lesion can present anywhere between the brain as well as in the spinal cord. Spina bifida can be spina bifida occulta or spina bifida cystica. And patients with neural tube defects, majority, over 90%, are affected by lower urinary tract. The meningomyelocele involves the lumbar, lumbosacral, and sacral part of the spinal cord in more than 90% of the patients. And even if it is fixed early in the life, the symptoms change later in the life because of the subsequently after the surgery because of the tethering of the spinal cord. Most of the patients with neural tube defect or spinal dysraphism, they present with areflexic bladder along with open bladder neck leading to urinary incontinence. The caudate venous syndrome is characterized by is because of the injury to the peripheral nerves or caudate vena due to the disc protrusion, spinal fracture, or iatrogenic lesions secondary to the spinal surgery. It affects the motor and sensory symptoms of the lower limb, buttock, perineum with abnormalities of sexual, bowel, and bladder function. Patients usually have urinary retention with associated underactive detrusor and loss of the bowel sensation, and they present with overflow incontinence, poor compliance, and detrusor overactivity. Now I will move on to 4 or 5 clinical scenario and would ask the participants to give their input in the chat box as well. So here you can see a few of the mine workers who are working in a coal mine, and suddenly the mine collapses, leading to injury to the thoracic spine, and there is this complete transaction of the thoracic spine at the level of T7, T8. This is another patient who had a history of fall on his head, leading to injury to the cervical part of the cervical spine and cervical part of the spinal cord. So this is actually a suprasacral and supraconal lesion and leading to spastic spinal cord injury. So this is the diagram over here. So can anyone tell me what are the impact and how would detrusor, how would bladder, bowel, etc. will behave in this scenario? So please write in the chat box. So no comments. So the sensations, there will be autonomic symptoms. The coordination will be lost. Completion of voiding will be lost. And there will be because of the suprasacral lesion, there will be dyssynergic reflex voiding with poorly sustained bladder contractions, poor compliance, and leading to a potentially unsafe bladder. The next scenario, a young child with history of injury to his brain. This is a CT scan. You can see that there is injury to the frontal lobe along with the fracture of the skull. So this is a suprapontine lesion. So the control of pontine micturition center is lost. So what are we expecting in this situation? Please write in the chat box. Right. So Mohammed Shoaib has written high bladder pressure, overactive bladder, Dr. Nazish Mughal, right? You're right. Sorry. Yes. So the voluntary initiation would be lost because the cortical control is gone. However, there will be coordinated reflex voiding, and there will be some social incontinence. But remember, Dr. Shoaib, that the pontine micturition center, since it is intact, so there will be no detrusor sphincter dyssynergia. Detrusor overactivity will be mild. So this bladder would be probably safe. Now, moving on to the spinal injuries and the lesions at the level of the spinal cord. So this is, so anyone can tell me where exactly the lesion is. So this is the cortex, brainstem, cervical part of the spinal cord, thoracic, lumbar, and sacral part. This black area is the complete injury or complete lesion. And the dotted area is actually the partial area of the cord damage. So where exactly the lesion lies? Anyone? So this is actually a T2 spastic paraplegia. Remember, you must know the normal part of the cord, normal functioning cord. So the T2 must be over here. So this is a T2. This will be a spastic paraplegia because the sacral part is intact, and this is a cord injury. So because the sacral part will be intact, so what will happen to the bladder, bowel, and sexual function? Dr. Nazish is right. This is suprasacral, but if you characterize the lesion, it will be spastic. Right. So DSD, okay, DSD is fine, but whether the bladder will function or not, bladder will be high pressure with upper tract in thread. Very good. Detrusor and bladder will be overactive. Very nice. So bladder will have a reflex activity, bladder, because the sacral part is intact. So bladder will have reflex activity. So bladder will be reflex. What about bowel? Incontinence. So why there would be incontinence? Do you think sphincter is gone? The perineal muscles and the pelvic floor muscles are weak or not? So the sphincter will be intact because the pudendal nerve is intact. So there will be no fecal incontinence. Again, the bowel would be again a reflex bladder. What about sexual function? What about erection? What about ejaculation? So erection is intact, right? So erection would be intact, but will patient be able to, initiate the erection or not? Dr. Sana has mentioned that ejaculation would be effective. So the injury is confined. It starts from T2 and it is actually ending above the level of the sympathetic output. Above it, it finishes. So the thoracolumbar part of the parasympathetic output is intact. So the patient would not be able to achieve erections, but will have reflex erections and reflex ejaculations. But the injury being in the upper thoracic area, patient would exhibit the autonomic dysreflexia. Next thing, so the injury is over here. It involves the lower thoracic and upper lumbar part of the cord. So the injury is T10, spastic paraplegia. What is the impact on bowel, bladder, erection, and ejaculation in this case? So because the sacral part is intact, so bladder will be reflex, bowel will be reflex. As this area, this level of lesion involves the thoracolumbar sympathetic outflow, so there will be absent ejaculation. But because the parasympathetic system in the sacral part is intact, there will be reflex erections. There will be some autonomic symptom, but no autonomic or sympathetic dysreflexia, because the lesion is in the lower thoracic part of the cord. So this is a lesion which is starting at T6 level. So the normal part of the cord is T6, but the lesion or the injury is extending all the way down to the sacral part of the cord. So will this be a spastic or flaccid paralysis? So this will be a flaccid one. So this is a T6 flaccid paraplegia. Because sacral part is gone, so bladder will be areflexic. What about bowel? What about erection? What about ejaculation? So you can see here that the incontinent bowel, okay, because the sphincter function is gone, areflexic, very good. The thoracolumbar sympathetic as well as the parasympathetic output is gone. So the patient will have areflexic bowel, absent erections, absent ejaculations, and because the autonomic system is gone, so there will be no autonomic symptom and no autonomic dysreflexia. This is the conus injury, isolated conus injury. So there will be low flaccid paraplegia, areflexic bladder, areflexic bowel. There will be some psychogenic erections, because a portion of sacral part is intact, and there will be psychogenic emission because the parasympathetic part is also intact. So this is the last slide. Again, this is for the third time we are reviewing this. So in the brain conditions, for example, in the CVA bilateral or CVA or central lesions, or in the cases of brain tumors, etc., what happens to the bladder? The bladder becomes overactive. There is neurogenic detrusor overactivity, and it is less common to have an underactive bladder. What happens to sphincter? Sphincter function is usually normal, and the bladder and bowel activities are coordinated. In suprasacral spinal cord lesion, what happens to the bladder? The bladder becomes overactive with neurogenic detrusor overactivity. Sphincter function, there is uncoordinated sphincter activity with the bladder, leading to detrusor sphincter dyssynergia. And in cases of sacral as well as peripheral nerve conditions, the bladder would be underactive. There will be impaired bladder compliance in some cases, and particularly later on because of the subsequent fibrosis. And sphincter function is also underactive. Thank you very much. Dr. Hamad, we can't hear you.
My apologies. So Nazim, thank you very much. You have very nicely simplified and comprehensively explained the difficult concepts, something that as clinician we all need to know. We move on from these two basic science, clinical bordering to clinical science presentation to urodynamic, which is the cornerstone of evaluation of patients with neurogenic bladder or neurological dysfunction or non-neurogenic symptoms as well. So Arslan Pervez, who is our senior resident, he will be graduating 2022, is going to talk about some of the basics of urodynamics. So Arslan, please go ahead.
Thank you so much, sir. I hope I'm audible. Am I audible?
Louder.
Yes,
we can just hear you.
All right, sir. So over the next 20 minutes, we'll be talking about the urodynamics. So when we talk about the urodynamics, this is basically a science that is concerned with the physiology as well as the pathophysiology of the urine storage and evacuation. And the basic aim of the urodynamic is to reproduce the patient's symptoms and provide a pathophysiological explanation by correlating those symptoms with the patient's urodynamic findings. So a test is as good as we know if we know what we need to see and what are the indications for having those tests. Or urge urinary incontinence, or there is mixed incontinence. Similarly, the patients who have neurogenic bladder and before moving on to invasive treatments, we need to have urodynamic findings. This is the EAU recommendations on which patients do we need to have pressure flow surgery, that is. Urodynamic, it's not basically just a simple thing. It's comprised of a wide spectrum of tests. We have the non-invasive urodynamic test, then we have invasive and the complex urodynamics. And today we'll mainly be focusing on the cystometry. That is a relationship between the storage and the voiding symptoms, and basically the filling phase and the voiding phase. So prior to moving on to urodynamics, you need to have a knowledge about what is the prerequisites, how a setup is performed, and how these tests are being done. Micturition is a private matter, and unless this is respected, urodynamics will be less than satisfactory. We need to have a negative urine culture prior to moving on to invasive tests, that is the cystometry. The patient should not be having constipation, and you need to review the history in terms of what's the bladder capacity, is there any incontinence, and what kind of medications the patient is taking, whether he is taking some antimuscarinics or not, or he's on alpha blockers. So we need to stop those medications prior to moving on to these tests. Then again, the indication that is very important, you need to have a review question prior to moving on to these tests. And the review question would be whether I'm looking for a bladder outlet obstruction, do I have incontinence in my mind, or if there is neurogenic bladder that I want to find. So we have in urodynamics, if you look at and you have just the uroflow meter, this is the flow meter, and this will be your non-invasive test, the uroflowmetry. But when we combine the uroflowmetry with the pump and the transducer, we have the filling phase, and this together we get the invasive urodynamics. So this is the chair of the urodynamics, and here we can see that this is the pump with the transducers being attached, and these transducers are basically kept at the level of the symphysis pubis to measure the readings. Similarly, when we attach the fluoroscope, we get the video urodynamics. So basically, going to the basics of the urodynamics, how these tests are being done is you have a catheter that is placed per urethrally into the bladder to measure the vesical pressures. Then there is another catheter which is put into the rectum, and as Dr. Nazim has already explained, you need to have physical examination of the patient. You need to do a digital rectal exam prior to putting in this rectal catheter to look at the anal tone and if there is any impaction. And this rectal catheter will give you ultimately the abdominal pressures. So we have the vesical pressures coming from the catheter that is placed into the bladder. We have a rectal catheter which is giving us the abdominal pressure. But what actually needed is the P detrusor, that is the detrusor muscle pressure. And this is actually a calculated pressure that we get by subtracting the abdominal pressures from the vesical pressures, and we get the P detrusor. So when we talk about your cystometry, this is basically a combination of a filling phase and the voiding phase. So in the filling phase, we have This is, you can see that we have the detrusor pressure, which is actually a calculated pressure. Then you have the vesical pressures and the abdominal pressures. And on the other hand, we have the voiding phase, where we are looking at the detrusor and the flow. So you need to know what are the things that you need to look for in the filling phase. And basically there are 5 things that we need to look. One is the sensations, whether the sensations are intact or not. The other is the capacity. Then you have the compliance and the detrusor overactivity. So the sensations are the first sensation, which is actually the time is the time where the patient actually becomes aware that there is fluid in his bladder, and this can be anywhere between 50 to 200 mLs. Then there is first desire to void, which is the normal desire, and any patient who has first desire to void, this is the volume in the bladder where he normally would go to the loo. A strongest desire is one in which there is no fear of leakage and the patient can hold on. And then there is urgency where there is fear of leakage and the patient would not be able to hold on and he has to go to the loo. Right before the urgent, at the time of the urgency, the capacity, that the amount of the bladder, the volume that we have in the bladder, it gives you the maximum cystometry capacity. And you need to know what is the capacity. So when we are commenting on the filling phase, we need to have a comment on the sensations, the capacity. Next up is the compliance of the bladder. And you would only know what things to comment upon if you know where to look for these things. And for the compliance, this is basically you need to look at the detrusor pressures. And because we know that the bladder detrusor has a capability of accommodation, that means it will relax and there will be no change in pressure over change in volume. So the capacity, the compliance, and then moving on, we have the detrusor overactivity, which is an abrupt rise in the detrusor pressure and then the pressure comes down. So these are the things you need to look for when you are looking at the filling phase. So as we have talked about the compliance of the bladder, which is actually delta V over delta P dat, that is with the change in volume, there should be no change in pressure. However, the compliance of the patient, it depends upon the rate of the bladder filling, with the physiological filling rate measuring from 10 ml per second, and the part of the curve that is used for the compliance. Similarly, the properties of the bladder, such as in cases of interstitial fibrosis or where we have the radiation to the pelvic region. So there is fibrosis and the patient's bladder become non-compliant. So you can see that there is this curve where we know the period that is measured, and the detrusor pressure, there is significant rise in the pressure with change in volume. So going over again, the filling phase, you are looking at the sensations, the capacity, compliance, and the detrusor overactivity. One other thing that we need to look in the filling phase is the leakage. And this leakage is basically measured in terms of the abdominal leak point pressure or the Valsalva leak point pressure. So the abdominal leak point pressure or the Valsalva leak point pressure is the pressure at the time of Valsalva or the cuffing, with which there is raised abdominal pressure and the patient leaks some amount of urine. However, when you look at the detrusor pressures, there should be no contraction in the detrusor. On the other hand, the detrusor leak point pressure is the detrusor pressure over which there is leakage, however, no associated detrusor contractions or no increase in abdominal pressures. And the abdominal leak point pressure is important to look for stress incontinence. However, the detrusor leak point pressure is important for the protection of the upper urinary tract, and no damage will happen to the upper urinary tract. So on the Valsalva leak point pressure, you can see here that the patient has got cough and this is labeled as Valsalva. And when we look at the flow rate, there is some amount of urine that is coming out in the flow meter. So this is the Valsalva leak point, and we can see that on Valsalva, the patient has some incontinence. So this is labeling as stress urinary incontinence. You can have this thing because of intrinsic sphincter deficiency or because of the hypermobility of the sphincter. On the other hand, when we talk about the detrusor leak point pressure, so this is the detrusor pressure with a significant rise. And when we look at the flow, there is some amount of urine that is coming outside. And you see that this is the pressure that is 32 centimeter of water where the patient has leaked. And this is important in terms of upper urinary tract damage. So you can see that the patient has got reflux, and on the other hand, he has got a hydronephrotic kidney because of this non-compliant bladder and the increased detrusor leak point pressure. The second part of the curve is the voiding phase. And in the voiding, the two important things that you need to look for is the detrusor pressures and the amount of the flow that it has got. So this is basically a uroflowmetry test with the detrusor pressures added to them. Based on this test, you will find that the patient has bladder outlet obstruction, which is measured in terms of outlet obstruction index or the Abraham-Griffiths index, which is P at Qmax minus 2 Qmax, and the patient could be labeled anywhere between obstructed to unobstructed. So this is basically a summary of what I have talked till now. So cystometry is to measure the pressure volume relations of the bladder. It comprises of two phases, the filling phase and the voiding phase. And the things that we have to look for the filling phase are these 5 important things. I would like you to remember these things and to comment upon these things when we go and move on to the cases. So the capacity, the compliance, sensation, stability, and the bladder outlet in terms of its leakage or the competent or incompetent. However, in the voiding phase, you need to look for the detrusor contractility, the bladder outlet, whether it's obstructed or normal or unobstructed, and the post-void residue. So these urodynamic tests, these are actually, they need to have a standardization of the terminologies, and the International Continence Society has standardized that you need to quantify capacity in terms of whether there is a reduced capacity or a normal capacity or it's an increase. I hope the basic concepts have been clear till now, and we can move on to certain cases. So moving on, we have our case number 1. So this is an 81 years old gentleman with multiple comorbids who presented and had a history of lower tract symptoms for the last 3 years that comprises of both the storage as well as the voiding symptoms. This patient had been on solifane, mirabegron, and the tamsulosin. So in our history review, we said that the patient's medications are very much important. And prior to moving on to the urodynamic test, these anticholinergic medications, they need to be stopped at least 1 week prior to moving on to these tests. So his digital rectal exam showed that the digital rectal exam, the inner tone was normal. His prostate was around 50 grams and smooth. Ultrasound showed a pre-void of 294 with a significant post-void of 142 cc and poor Qmax of 8 ml per second. So the question that we had here in our mind is an 81 years old gentleman, keeping in view the EAA guidelines, which say that any patient who is over 80 and he has a lower tract symptoms and moving on to some surgical intervention, you need to get a urodynamic test on these patients. So we did perform a urodynamic investigation on this patient. This patient had both stress as well as this patient had both the storage as well as the voiding lower tract symptoms. So this is the filling phase of the urodynamics. Here we have the vesical pressure, the abdominal pressure, the detrusor pressure, the flow, and the vesical volume, that is the volume of the water that is infused. So when we look into the urodynamics, we need to know a few important things. Number one, these peaks that we can see in all the 3 pressures, that is vesical pressure, the abdominal pressure, and the detrusor pressure. And these 3 peaks, basically, they are the cuffs, and you need to perform these tests to know if the patient has all these 3 lines, they are patent and not, and they are working. So in this patient, when we perform the urodynamic test, initial part of the urodynamic test, the compliance was pretty much normal. But later, in the later half, the patient had a rising compliance, and this activity that we can see in the filling phase, which should not have been there. This is basically the detrusor overactivity, which is terminating into, and there is this terminal incontinence that we can see in the filling phase. When we look at the pressure bladder capacity, you need to know the amount of the volume that has been infused. And in this case, we infused around 181 mLs. So around 181 mLs, the patient had a rising detrusor pressures. There was some leakage. He had a rising non-compliant bladder, and the sensations were pretty much reduced. Okay. So the infused volume was around 161 mLs. He had a significantly reduced sensations. First sensation at 131 ml, the second sensation at 163, and we had to stop at 174 mLs because the patient could not hold anymore and he leaked some amount of urine. The other part of this curve would be the voiding phase, and this is the voiding phase. In the voiding phase, we can see that the detrusor pressures are well above 100. So this patient has a high pressure system. But on the other hand, when we look at the flow with this high pressure, the flow is pretty much poor. It's less than around 10 ml per second. So it's around roughly maximum up to 8 ml per second. So this patient had a high flow system and poor high pressure, poor flow system. So keeping in view the history and the urodynamic test that we had, you need to make an assessment, a diagnosis, and management. So in the filling phase, you have to comment on these 5 things in your assessment and make a diagnosis, and then move on to the management. So in this case, we had a small capacity bladder of around 161 mLs. He had an abnormal low sensations with a lower compliance and terminal detrusor overactivity, which was terminating into incontinence. However, on the voiding phase, we had a high pressure system with a poor flow and significant post-void residue. So a working diagnosis is bladder outlet obstruction, and your management based on his history and the findings would be to go for a TURP and anticholinergic medications in this case. So in the second case, I would like, our participants to comment in the chat box what they think are the capacity, the compliance, and the rest of the parameters that I have shown. So this is the case of a 27-year-old male who had no comorbids. He has a history of a road traffic accident around 1 year back with a spinal cord injury at the level of L4, L5. He is currently doing clean intermittent catheterization 4 to 5 times per day. So his presenting complaint was basically urgency and urge incontinence with increased frequency. On examination, we have a paraplegic patient whose sensations are intact. He has an intact anal wink and a bulbocavernosus reflex. Our lower limb shows an exaggerated reflux with upper going planters. The digital rectal exam showed an increased anal tone. The prostate is small. However, on ultrasound, he has bilateral moderate hydronephrosis with significant post-void residue. So this is the filling phase of this patient. I'd like you to write in the chat box what are the different things that you can see. So number one, first thing first, these peaks that you see in the filling phase, what these peaks correspond to. I can see no comments in the chat box. However, these peaks actually, they are the cuff impulses that we talked about. So a normal patient has to give cuffs every 1 minute to look for the patency of this. Yeah, tubes. Moving on, what is this blue thing that you can see? There is a significant rise in the detrusor pressure and falling down. Dr. Sana is very right. So these are basically the retrusor overactivities. Here you can see that the vesical pressure, we can see that this rise in the vesical pressure. However, when we look at the abdominal pressure is pretty much cohesive, and there is no rise in the abdominal pressure. So these are the retrusor pressure. These are the retrusor contractions because of which we can see a rise in the vesical pressures. And this is associated with the leaks. So this patient has an infused volume of 513 cc. These are the sensations. This is the compliance. You can see at the compliance, these are the retrusor overactivities, and there is some leakage. So when we make an assessment of this patient, we would say that this patient has got a normal capacity bladder with intact sensation, some retrusor overactivities with incontinence with a normal compliance bladder. When we look at the voiding phase of this same patient, so this patient, he has a retrusor pressures of well over 80-90 centimeters of water on voiding. However, on the other hand, he has a poor flow on the voiding phase. So the assessment with a normal capacity, low compliance, normal sensation bladder, he has severe retrusor overactivities at every 100 mL. With the associated incontinence, he has got a high voiding pressure, a poor flow system with significant post-void residue. So do you people think that this patient has got a healthy bladder, or is it a safe bladder? Yes, so this is not a safe bladder. This patient has significant high retrusor pressures with a poor flow, and he is at risk of having upper tract damage. So the treatment in this patient would be to go for the anticholinergics, keep this patient on clean intermittent catheterizations, have intravesical botulinum toxin, and the role of sacral neuromodulations. Moving on to case number 3, this is the case of a 49 years old female. She has history of depression, underwent a fibroid hysterectomy for fibroid uterus, and she presented to us with history of lower tract symptoms, with basically the voiding symptoms which were refractory to anticholinergic medications, having both stress urinary incontinence and urge urinary incontinence. So on examination, the PAT test was positive on cuff. There was no pelvic organ prolapse. She had bilateral kidneys were normal, and post-void residue for only around 23 ml with period of 790 ml. So can you guys comment on this filling phase of this patient? What do you think these things are here that we can see this erratic findings that we are looking in all the 3 readings? The vesical pressure, the abdominal pressures, and the retrusor pressures. These are basically the artifacts that we are looking at. She has some leak or incontinence with the rise in retrusor pressure, and she has basically a stress incontinence. And when we look at the voiding phase of this patient, her retrusor pressures are pretty much within the normal limit, and she has a normal flow. So assessment is a normal capacity, normal sensations, a normal compliant bladder with terminal retrusor overactivity with associated incontinence. She has a normal voiding pattern, normal pressures with a normal flow, and insignificant post-void residue. She had mixed urinary incontinence, and the treatment that we had for her would be anticholinergics with some TVTs and TOTs. This was the last case for today. I hope you guys learned something. If you have any questions, please feel free to ask in the chat box.
Thank you very much, Arslan. I think you have done justice to the topic. We move on to the next presentation, and this is by Professor Raila Mohsen. She is gynecologist. However, she has branched out into urogynecology. She did fellowship from Australia, and subsequently she has trained a wide number of people into the fellowship of urogynecology. And Dr. Mohsen is going to talk about overactive bladder from behavioral modification to surgical treatment. Rahila, floor is yours.
Thank you, Hamad. I hope you guys can hear me.
Yeah, we can hear you, we can see you.
Okay, thank you very much. So my slide sharing should work actually. Share screen. Yes. So overactive bladder from behavioral modification to surgical treatment. After these three heavy talks, it's going to load your brains. I'll try to make it interesting and keep you guys focused and a little bit of challenges to your gray matter. So I'll be focused about, I think it would be nice if I can give you a definition of OAB, the various spectrum of management that we believe in, and how do we formulate a management plan? What do we do in practice, and what is available in hand? What is in this Southeast Asian zone? How do we choose the mode of treatment? And finally, the take-home message. So everybody, I guess, here are the urologists, or I could hardly see any urogynecologists. I hope this overactive bladder by the ICS given back in 2002 is a spectrum of frequency, urgency, nocturia with or without incontinence. If this is with incontinence, so a little bit of change from urge, they now call it as urgency incontinence, and this is going to be a wet OAB. And even if somebody has urinary frequency, nocturia, and urgency, but doesn't leak on the way to toilet, it would still be OAB, but a dry kind of OAB. So what is the guideline to begin treating, to begin formulate a management plan for OAB? The AUA and SUFU, both guidelines state, and it's a mandatory, the clinician should engage in diagnostic process to document symptoms and signs that characterize OAB and exclude other disorders. And how do we exclude in the busy clinic, for example, Tuesday clinic, I used to have 66 patients with urogyne, and I formulated this mini mental examination to just exclude what the Nazim said about the Parkinsonism, dementia, and multiple sclerosis. So it is a mandatory because it is a must thing, because if you don't do this, then the anticholinergic therapy might aggravate the symptoms of neurological diseases. So it's a must thing. So now from behavioral intervention to the spectrum of to surgical treatment of OAB. So what is behavioral intervention? I've read about more than 50 papers, not now, but because we had a trial of overactive bladder at AKU. So the different papers who define behavioral intervention as simple lifestyle advice, bladder training. Some papers include pelvic floor muscle exercise into the bladder training, and some even include drugs, the antimuscarinic drugs or anticholinergics into the behavioral intervention. Well, I disagree with that. I would say that the good bladder habits, including lifestyle, like if you are into coffee and tea or alcohol, or you're drinking a lot, then start using decaffeinated coffee and reduce the drinking from habitual to maybe social drinking, and the things like that. So this is good bladder training, avoid constipation. It's very hard to say and to practice that maintain your weight or reduce weight reduction, or how to avoid obesity or even treat obesity. Well, I think now we have an obesity clinic at AKU. And bladder training is again a very challenging part, because how many would have this access to pelvic floor muscle training? For example, even at AKU, we don't have pelvic physiotherapist. So what we rely upon is that the general physiotherapist would train along with the urologist, somebody like Dr. Nuzhat or me, gain hands-on experience in clinic and would start practicing pelvic physiotherapy. But that's not what the literature says. When we talk about pelvic floor muscle training, we talk about the pelvic physiotherapist who would use the biofeedback assisted training. And that's actually is very effective training. And then, as I said, the drugs, somebody would say in the first line of management or along with the behavioral intervention, I would say no, it's a second line. And then the third line, and Botox, surgical treatment, sector neuromodulation, and the others. We'll discuss one by one. So according to my own definition, the first line or initial management begins with the lifestyle. As I said, the weight reduction, avoid constipation. Don't take this Nestle bottle long. Drink according to the desire of the body, temperature requirement. For example, in Karachi, with the 42 degrees this year, you might as well need 3 liters or maybe even more than that. But just as a fashion of Nestle drinking is not advisable, because remember what goes in, that comes out. Then you see we teach little bit of like the cross leg positions, or gradually postponing the desire to make fit till you attain a normal avoiding volume that would be optimal. And then we start giving Kegels exercises or the pelvic floor muscle training. Simply we teach patients by putting hand in the posterior vaginal wall, but eventually they learn it. If very few would learn this, very few would be compliant. So I'll just refer to my own study, but I guess this paper says that the optimal duration is 4 to 8 weeks. In my practice, I use a minimum of 12 weeks or 3 months. The second line, according to this paper and my own definition, is second line includes pharmacotherapy. And this is initiated if this behavioral intervention, which is the lifestyle, good bladder habits, and pelvic floor muscle training with or without biofeedback. So this first line is a big spectrum, which whatever you do would reduce this burden of OAB to less than 30%. And probably in our culture, it's not available one. And second, compliance is the major issue. So most of the setting in Pakistan, we begin with the pharmacotherapy. And patient is also, they're short of time, they may not be able to learn for so many other reasons. So the current classes of medication include anticholinergics, beta-3 agonists. I guess everybody has an access to these medications. Choice of class of medication depends on age, comorbidities, concomitant medication, formulary restrictions, like the absolute contraindications, and trial of pharmacotherapy. According to this AUA guideline is 4 to 8 weeks. I would say 12 weeks. And of course, we have to manage. We have to not manage. We have to first counsel the side effects. For example, with antimuscarinics, most by and large women would get constipation and dryness of mouth. Well, with the M3 selective antimuscarinics, solifenacine and darifenacine, this dry mouth and constipation is markedly reduced. This beta agonist is contraindicated in uncontrolled hypertension. We do counsel about to guard against the high blood pressure. So this is my own study, and we had this overactive bladder trial back in 2014. It was published in 2018. This is the effect of bladder training and behavioral intervention in female patients with overactive bladder syndrome. And we were lucky to have 3 arms of study, arm A, B, and C. The A arm included those who only received good bladder habit and behavioral intervention. Group B, 50 patients in each. Group B received the pelvic floor muscle training at home, which was taught in the clinic, in my own clinic, and then later they were asked to practice at home. The 3 is thanks to Nahid Kapadia, who was our pelvic physiotherapist. Now she has moved outside Pakistan, but she used to do biofeedback assisted pelvic muscle training and gave us the wonderful results. So our primary objective was to see the efficacy of these 3 arms, intra-group and both intergroup. And the secondary objective was to assess the improvement in symptoms by each method independently and comparison with each other. So, and the aim was to define the first line of management among this behavioral intervention. And let's see what we got. This is the pair tree test, which showed we used this urogenital distance inventory short form and the impact incontinence questionnaire short form 7 for all these arms, and the study continued for good 3 years with 47 follow up in the group arm A, which is just restricted to bladder training with good bladder habits, and B and C had 50 groups in each. And you see, if you look at the p-value, it shows the marked reduction in the urogenital distress inventory scores before and after treatment and IIQ 7. So it means that whatever you do, either the training or the pelvic muscle, with the bladder training, with the behavioral intervention in terms of good bladder habits, or in terms of the lifestyle modification, or you do the pelvic muscle training, or you use biofeedback, this would have a marked improvement in the symptoms. So what is the harm if we can start all these three simultaneously? That was the take-home message of this study. So this is what we concluded, that comparative results in 3 arms are not statistically significant. So I guess we can start right away using all 3 things: the lifestyle modification, pelvic floor muscle training, and if you have available a biofeedback assisted pelvic floor muscle training. So that's really makes a huge difference. Probably patient has a good compliance. What if this first line of treatment doesn't work? So we have the old, I guess, when I started my fellowship in 2003 to 4, we had this oxybutynin, we had this tolterodone, the name of letrozole, and later came the slow release letrozole 8 milligram and the patches, and now recently we have dariphenacine, solifenacine. These are the drug of first choice for the treatment of overactive bladder. When this first line treatment fails, although studies have demonstrated similar or even better results with the use of solifenacine and low frequency of complaints related to dryness of mouth and constipation, but abandonment of treatment due to adverse events were similar in the A or B. So this, what is this A and B? A is the oxybutynin and solifenacine, and B is this beta agonist. So what is the role of antidepressant? People, I think that even GPs in Pakistan, they write this oxybutynin. Actually, they've stopped writing. They're very fond of writing tolterodine, letrozole. So, but I have seen a couple of prescriptions where they write antidepressants. So I'm not against the use of antidepressants, but recently, after attending the short psychiatry course in clinical psychiatry from this AKU guys, this is actually not short. This was online course, and it's spread over 6 months or 4 months, I guess. So what I learned from that psychiatric course, that we have to be very careful when we prescribe this antidepressant, which have a small anticholinergic effect, and as well as an alpha adrenergic action on sphincter, because it inhibits the reuptake of norepinephrine and serotonin both, and it relaxes the detrusor muscle, increases the intrauterine pressure. So it leads to good storage, but remember that adverse events, especially cardiovascular, with the possibility of arrhythmias, 1, and 2, if you add antidepressant with the patient who has underlying antipsychotic medication, or who has psychosis, then that increases to the increased tendency for suicide. So this is something which has really scared me to death. So I'm very skeptical with use of antidepressant. So the new drug, new for the Pakistan at least, the beta adrenergic receptor agonist in treatment of idiopathic bladder overactivity, which is like 70% of OAB is idiopathic, and this 30% is what Dr. Nazim has discussed, that the detrusor activity in combination with neurogenic bladder. So this 70% that all of us, even the gynecologists and even GPs see, is they're using, as I said, detrusor or and with the major side effect of dryness of mouth and constipation. And recently, the solifenacine, the low dose 5 milligram, but this beta agonist, mirabegron or Vibaga, this has less of side effects. These two documented, for which the patient used to drop this treatment. So this is very effective against minimizing the side effect. But is it really effective in minimizing the symptoms of OAB? So you may not laugh with my comments that the less side effects and the less efficacy. The drug which would have effect would have side effects. So with my 3 years experience with Vibaga, whether 25 or 50, neither I'm happy with the effects, nor I am unhappy with the side effects. So you choose. So well, it's not my drug of choice to begin with. I use it as a polytherapy. So this is my own personal level X experience or C level of evidence, but the literature also has says the use the recommended use is polytherapy. The effectiveness of mirabegron, this is the 50 milligram, was not significantly different from other active treatment except for trospium. Now, unfortunately, the trospium 60 milligram is not available in Pakistan. And solifenacin 10 milligram, yes. And physiotherapy 8 milligram slow release patch or slow release we don't have in Pakistan. So if you compare these three drugs, so they are all more effective than the mirabegron 50 milligram. So as I would again say that with polytherapy, yes, it has a role. So what is the role of combining therapy? As I said, the polytherapy, mirabegron or anticholinergics with idiopathic. At phase 3 RCT, a good number, 1,306, female more than 18, multicenter, double-blind center. They assess the effectiveness of combination of solifenacin, mirabegron with monotherapy of solifin 5 milligrams. So I'm very unhappy with the trial. Why solifin 5 milligram? Why didn't they use the 10 milligram? And then they explored the dose response relationship. And then eventually they had to use this. They divided into 3 arms that they did use the solifenacin 10 milligram. And what was the take-home message? After 3 months, the drug combination proved to be superior to solifenacin 5 milligram, but the combination was worse than the monotherapy of solifenacin alone using the 10 milligram. So that's if you are, I'm sure that my urologist colleague would agree. Solifenacin 10 milligram is good enough. Well, if somebody has really bad OAB, wet OAB, there's no harm in adding 25 milligram of Nibega. So what are the guidelines? The clinician must use caution in prescribing antimuscarinics in patients who are using other medication with anticholinergic properties. The concurrent use of other medication with anticholinergics activity may potentiate the side effect of antimuscarinic class of OAB medication. This is very latest 2019. So so just eyeball this statement. This is really very serious because I can have another talk on this topic. I've already talked because clinicians, they are not very careful in prescribing antimuscarinics with beta-3 adrenoreceptor agonists because all of my patients are 65 plus. Now, when the Western literature says a failed patient, they say 80 and above. Keeping in mind the average age in Pakistan, I would say the 60 plus ladies have as many comorbidities as in Western countries, 75 plus. So this cognitive defect, particularly memory difficulties, have been reported in response to antimuscarinics, and clinical experience suggests that elderly patients may be particularly prone to these adverse events. And you see, it scares me to death when I see the elderly patient, 80 years old, receiving polytherapy and with recurrent UTI receiving ciprofloxacin. I'm sure that by now, all of my colleagues, they know that this ciprofloxacin drug, so commonly used in 85, 80 is strong contraindication because of aortic aneurysm. So I have stopped using since a year. So that's just a take-home message for my junior colleagues. So dementia patient antimuscarinics should be used with extremely precautions and is contraindicated because it actually aggravates the symptoms of dementia. So what if we don't have these very effective management of these drugs? So are there other drugs? There are a number of trials. I mean, literature is full of this praise for the Vibegron, and the phase 3 trial results are coming up. They met the co-primary endpoint, rapid onset of benefits, sustained efficacy and safety, no effect on this enzyme that causes the enhanced metabolism, as with the mirabegron. Solabegron, it has completed 2 phase 2 trials. Novel introduced gene therapy. I think this would be I think it's high time that for Dr. Hamad at least to start stem cell therapy for the bladder, and we have the stem cell center. So this is really going to be an effective phase recruitment ongoing in the phase 2 trial. So now comes to the very controversial topic: what treatment should we use if the drug fail for OAB? When should we label the failed OAB treatment? So refractory OAB, and what really works when the drugs fail? So the literature says the refractory OAB after 8 weeks, and I beg to disagree with literature. I would say 12. If the 12 weeks of first line of management fails, It's my practice to start off with the pelvic floor muscle training with the good better habits and one anticholinergic. So if 12 weeks of all these three fail, with good compliance, I would say the refractory OAB. But in my clinical practice, the patients turn up, it takes around 6 months to label somebody as refractory OAB. And then what is the third item arrangement, which is actually gels with my topic from behavioral to surgical. And by the way, this what we call as surgical sacroneuromodulation, yes, it is surgical, but percutaneous tibial nerve stimulation is not surgical, but it comes in the area of surgical. And autobotulinum toxin A, some papers they include in surgical, some papers they don't include it. But I have included this slide as a surgical. So the orna-botulinum toxin, I would pause here and would ask my audience to write in chat box how many have experience with this and what is the cost in Pakistan. So chat, how do we go? So nothing in chat box. So if nothing on chat box, then I would assume, number one, can you hear me?
Yes, Raila, we can hear you very well.
Okay.
I have some experience,
Okay.
very little,
Yeah.
few cases. I'm not really sure. I think it's about 45,000 rupees for the vials.
Okay, thank you, Hamad. So this is 45. I think Hamad is telling me the cost of orna-botulinum toxin A, and the total procedure, 100 units are injected via cystoscope, and it's a daycare procedure. And with you have to counsel the patient, you have to numb the bladder, you have to counsel about the infection, you have to counsel about the urinary retention, and probably in my experience, it doesn't require the CIC, but still you have to counsel. And the package, minimum package, to the best of my knowledge, was in my previous experience was 200,000, and this treatment was effective as with evidence-based literature for good 6 months. And now with my new setup, I will show you by the end of my slide, it is Hamad only 100,000, and the cost of injection is only 22,000 rupees. And this is USA made orna-botulinum toxin A. So this is really cost effective, and I have switched now all of my refractory OAB patients for this daycare. It's a fantastic procedure and wonderful. So I think it's a high time that you should start advocating with Botox injections for better results. Very good results. Initial results are very promising. So percutaneous tibial nerve stimulation, a systematic review and meta-analysis, very recent one. And this is not a rocket science. This is very easy daycare setting. And this is 2,461 pages. I think the good number of trials that we can rely on. And they saw a significant clinical effect in voiding frequency, a significant reduction in nocturia and urgency episodes, and with the wet OAB, and with the urodynamic evidence that they did achieve the maximum systometric capacity and compliance, the pool success rate was 0.68. As you can see, it's very good. The major complication was the pain at puncture site, but the incidence was very low. So they concluded that posterior tibial nerve stimulation has been found to be an attractive option in patients with refractory overactive bladder, with about 60% patients showing a subjective improvement. I think you just need to have a setup where the patient can, you need to have volume. I'm sure at AKU volume is not an issue. They are like with Dr. Nuzar, Dr. Hamad, Dr. Rasi, and now Nazim and a few juniors coming up. So in my clinic, the 70% of urogyne volume was OEP. So this interesting fact that this PTNS, posterior tibial nerve stimulation, I would say posterior tibial nerve because this is posterior aspect of the deep malleolus, and this say percutaneous tibial nerve stimulation, and then transcutaneous tibial nerve stimulation. The literature has used both these words, but look at the terminology. transcutaneous nerve stimulation has been found to be as effective as a maintenance therapy after percutaneous nerve stimulation. So this is very latest Journal of Physiotherapy 2018, where I guess this percutaneous should be replaced by this is a published paper actually with posterior tibial nerve stimulation. And this transcutaneous can be taught and can be practiced at home. I've read this paper in depth, and I would ask you, my colleagues, to please read this paper, and somebody can have the courage to correct it. Well, I read it and I'm sharing it. So this is not my cup of tea. My colleagues, I'm sure Hamad and Dr. Farhat Abbas and few others are doing this sacral neuromodulation implantable system that only these guys can do, that stimulates the sacral nerve, modulating the neural reflex. Sounds very good. In the long term, I'm not sure, but especially helpful in patients who are unwilling to practice CICS with other modalities of treatment. So this artisan, this system is available, relaxed OAB studies. This system-based trial found that it was useful in this group of patients. It was supported by the National Institute of Healthcare Excellent Life Guidelines, which we use at AKU as a standard practice. So this is also very latest. So last slide, I guess, the augmentation, the ileal, intero augmentation system. Let's say if you're using the ileal, the gut as a diversion, and if you're using the auto augmentation. What is auto augmentation? Anybody who can comment on auto augmentation? Come on, yeah, this is a group of urologists. What is auto augmentation? Auto augmentation of bladder. What is the other name for auto augmentation?
Detrusor myomectomy.
Yes, detrusor myomectomy. So detrusor myomectomy gives wonderful results. The literature is full of praise for this. I have done only one with Razi Beaban, only one procedure with Dr. Razi, and patient had remarkable improvement in symptoms. But I'm not sure if you guys are doing, but literature says it's effective. Well, augmentation, this using the shortcut, it is associated with the renal dysfunction and so it carries significant morbidity and other complications. So I guess with this next slide, where is my next slide? Oh yes. So the future possible surgical options are intravesical installation of liposome, encapsulated media toxins. This will avoid anesthesia and as a clinical procedure. Selective denervation of bladder by radiofrequency ablation. This is also daycare. And pudendal neuromodulation is like acupuncture, daycare. Dorsal digital nerve stimulation in clitoris. All these papers are coming up, and they all seem to be very promising. So I would say for my junior colleagues that you define your first line of treatment. For me, it is a behavioral modification, pelvic floor muscle training, if biofeedback is available, along with monotherapy. This is my own practice. So tolterodine 4 milligram or sulfonacine 4 milligram, 5 milligram for 4 weeks. If this is effective, continue using for 12 weeks. If this is not, label it as a refractory AB, but before you label, add 1 sulfonacine 5 milligram, give a trial for another 6 weeks, and then jump on to, I know only Botox, so I jump onto that. And I wish we could have PTS at AKU, but unfortunately, despite the effort of Nuzat, me, and my team, we could not. And this is my new place where I work, and these guys have promised me to get posterior tibial nerve stimulation, and I believe in them because they have been successful in formulating our pelvic floor unit with 3D pelvic ultrasound and the state-of-the-art urodynamic studies with EMG and the anal manometry. So I'm very happy with my new workplace. You guys are welcome to join me for any short courses, lectures, conferences. Hope to see you. Thank you very much for patience.
Thank you very much, Professor Mohsen. Wonderful talk. And I think you have very nicely covered a difficult subject, something that we see very frequently and often wonder what would be the next step or what should be the next step in management. From there on, we move on to the male LUTS and BPH. probably one of the commonest clinical presentation when in your outpatients. And to lead this case-based discussion, we are honored to have Mr. Nanda Dhanasekharan, who has been our invited guest for this session, and he will be joined by Mr. Fahd Khan, again from Birmingham. I see if Salman and Khalid has joined us. Salman, are you around?
Yes, sir, he is on.
Okay, wonderful.
Yeah, I'm on.
Great. And then we have Tariq Sami. I don't see Tariq Sami. I don't know if he will be able to join us. But Ananda, the stage is yours. Please go ahead. Thank you very much for this.
Thank you. Thank you, Professor Athar. Thank you for the opportunity again. And we are so happy to see this seminar going on quite strong year by year. Thank you for giving the opportunity for the second time in continuous. We hope that we will continue this for the future years also. One of the topic which we are going to cover today is the male LUTS due to BPH. The actual terminology is BPE, because BPH means benign prostate hypertrophy, which is a pathological diagnosis, while BPE is the normal clinical term. There is another term, BPO, which is benign prostatic obstruction, which is due for the urodynamics. In this talk, we will predominantly look into the surgical aspects of treatment of male LUTS. We have covered a lot on the medical aspects in our last seminar. I will share my screen and start. Okay. So again, thank you for inviting for this 10th Karachi Urology Week. We'll start with a scenario. A 68-year-old man presents with BPE referred by GP. Prostate size is 80 grams. PSA is normal at 4. Patient tried tamsulosin and finasteride for 18 months as bothersome LUTS. IPSS is 20 with quality of life 5. His flow rate and bladder scan showed a maximum flow rate of 8. He voided 315 ml. His average flow rate is 4 with a residual urine of 32. He enjoys a very satisfactory sex life. There is no problems with erection or ejaculation. How are we going to proceed? Because of the lack of time and since the chat box is the only way we can discuss, I think I will go ahead with the discussions also. So this patient is a quite clear failed medical treatment. We have tried tamsulosin and finasteride, which is not working. So the best way is to discuss the surgical options. There are some absolute indications for surgery and there are some relative indications. Recurrent refractory urinary retention, overflow incontinence, recurrent UTI, bladder stones or diverticulae, treatment resistant microscopic or macroscopic hematuria, dilatation of upper tracts. These are all absolute indications. Why they are absolute indications? Say, for example, if you take bladder stones and diverticulae, this shows that the stones have formed secondary to the stasis of the urine in the bladder, and the bladder has already started having diverticulae. If these patients were not served with the appropriate surgical intervention, the bladder detrusor will go for further failure. If there is a possibility of urine tracking into the upper tracts, it will result in upper tract dilatation and patient will present with high pressure chronic retention or renal failure. So those reasons are the absolute indications for surgery. Coming to the relative indications or the patients who are responding to the tablets, but not having a very satisfactory outcome and requires much more better improvement. So our patient obviously haven't had any improvement with the combination of tamsulosin and finasteride, and hence we are discussing the surgical options for him. Now, how will you do a TURP surgery? We have few named methods. If you can bring these named methods during your Viva presentation, that will give you a good amount of marks. Instead of just explaining that, I will consent the patient, I will make sure the checklist is fine, give appropriate preoperative antibiotics, and make sure patient is in GA and appropriately prepared and draped. These are all the common preparations for any surgeries. And then Rather than discussing only the monopolar and bipolar energy source and explaining the examiner that you will start your resection from 9 o'clock or 3 o'clock, etc., you can spell it out with these named techniques like Nesbitt's method, Alcock and Floch's method, Moyne-Meyer's method, and Brand's method. They are all very well established methods. For example, Nesbitt means resection starts from 12 o'clock and then continuing to the lateral lobes and resected from top to bottom. And all the methods were there in the slides, and I'm sure this program is recorded and you'll be getting the recorded slides. So try to have a named methods even for TURP. If you could exhibit your strong theory knowledge in the discussions of TURP, which is like a basic bread and butter for all the urologists in the world, then when we discuss the higher, newer technologies, if you perform well in those technologies also, that will fetch you much more better marks. What is the evidence behind the monopolar TURP? Multiple evidences, multiple meta-analysis available. We have around 20 to 30 randomized control trials available, Qmax improvement, significant reduction of IPSS, quality of life improvement, significant reduction of post-void residue, all very, very nicely proved. There is a TURP rate of 8.3% in 10 years. Complications of monopolar TURP, risk of TUR syndrome, it is now getting much more lesser because of mainly the bipolar TURP. The usual quoted rate is less than 1.1%. Short to mid-term complications like TUR syndrome, acute urinary retention, which may get better later in the follow-up, clot retention, and UTI. Long-term complications like urinary incontinence, urinary retention can also will improve, but complications like bladder neck contracture or urethral stricture will need some secondary intervention. 60 to 90% patients will end up in retrograde ejaculation. This is very important because now we have few newer technologies which will preserve the erection and ejaculation. So if your patient is a very young patient, 40s or early 50s, wishes to preserve the ejaculation and erection, and there is a possibility the patient may be even hoping to have a child, in those patients, be very careful before offering monopolar TURP or even bipolar TURP. Reoperation rate, as I said, is 3 to 8% in 10 years' time. Bipolar TURP, it is available at least in few of the centers, I believe. They are the one where the electricity is completed locally. The energy is confined between the active and the passive loops. And there are few types where you got the loop with two loops where the current is covered in the loop itself, or the quasi bipolar one where the current passes into the sheath of the bipolar sheath and it is drained. The main advantages are it eliminates TUR syndrome, very low chance for clot retention and blood transfusion. I don't really buy few things like, for example, low clot retention, shorter irrigation time, shorter catheterization time. These are all due to the individual surgeon's expertise and also the individual patient's prostate anatomy. But elimination of TUR syndrome is a very good point if you are going for a very large gland, 120 cc, 140 cc, if you want to resect in one go, you want to resect more than 60 minutes, like 90 minutes, bipolar TURP is the best way to go. Having said that, there is no foolproof that your normal saline will not cause TUR syndrome. Even with normal saline resection, if there is excessive absorption, it can cause dilution, it can cause TUR syndrome, but it is much, much less chance when compared to the monopolar TURP. The other main advantage is patients who got pacemakers or defibrillators in the heart, or foreign bodies like screws or plates in the hip, where you prefer not to have unnecessary current dissipation into the body tissue. In those patients, bipolar TURP again comes into play. The EAU 2021 guidelines, which I hope you are all following up, should offer bipolar or monopolar TURP if the prostate is between 30 to 80 ml. If it is more than 80 ml, we need to be very careful in offering the TURP as a choice, because as you know, there is the surgery holmium enucleation, or any enucleation is better suited for larger prostates. Bipolar transurethral vaporization of the prostate, almost a similar technique, but there is a special electrode which is like inverted mushroom shape. Using that, you can vaporize the prostate. It is a good one if the prostate is very small and you're not really looking for removing the tissues for the histology purpose. EAU 2021 is again offering bipolar vaporization for prostate between 30 to 80 ml. Coming to the lasers, you all know the thulium laser, which can be used both as a vaporization technique and also as an enucleation technique. It is a continuous wave mode laser. You don't need to really memorize the wavelength of 1940. Compared to TURP is a longer operation time and the laser takes longer time, but catheterization and hospitalization is much less. Blood loss will be much less. Always laser is much better hemostatic than monopolar or bipolar or any energy source. That's why laser is very good in hemostasis. It always creates very less blood loss. It is very suitable for patients on anticoagulants, even though you can stop the anticoagulant adequately. The next option is transurethral incision of prostate, which is suitable for very small prostates, less than 30 cc. Usually we see them in youngish patients like 50s and early 60s, where there is not much prostate tissue, bladder neck incision, and it can be done by using monopolar or bipolar methods. Coming to enucleation, enucleation is suitable for glands anything more than 40 cc. Maybe in the early learning period, we'll be starting with a lower sized glands. People have done enucleation in single sitting for glands even up to 500 cc, 700 cc, etc. If you see the Twitter feeds, you can see sometimes rarely people report removing 1000 cc of prostate using the enucleation technique. Technique is important, expertise of the person is important. Otherwise, it's a very straightforward technique. Wavelength of holmium is 2140. This is the another one you guys need to memorize. There are multiple meta-analyses which showed that holmium results in longer operation time when compared to TURP, but we are not comparing apples with apples here. TURP is for smaller glands less than 80 cc, while holmium is for larger glands. Shorter catheterization period. In UK, there are a lot of centers which are offering even a day care holmium enucleation service. Patient may go home with a catheter. Next day, the catheter will be removed. The same surgery, enucleation can be done by using thulium. As I said, all the lasers were almost equivalent in the result. Thulium is slightly different in the hemostasis wise, but the outcome is almost same. The man behind the machine is more important than the machine as far as the lasers are concerned. As per the EAU 2021 offer laser, whether it's a thulium or holmium for the larger glands. Green light laser, we can use it for enucleation or we can use it even for vaporization. The wavelength is 532, but otherwise working principles are almost the same. It has we have three types of lasers from the company. The 180 watt XPS is the one which has the best coagulation and best cutting modalities. The previous generation 120 is good in cutting, but coagulation is not brilliant. I think the much more older generation 80 watt, I don't think many people are using it now. So enucleation is equally good. If your institute has already got green light, you can use it for vaporization or enucleation. There is no need to buy or invest in holmium just for the sake of another energy source. But if you have holmium, the advantage is it can be used for stones also. Already we have a little bit lagging in time. So without much delay, I will touch upon the newer energy sources. Before getting into the newer energy sources, I will invite the other two panel members. Fahad, you want to add anything on the TURP or enucleation procedures, please?
No, not particularly. I think, well, the thing that I do want to, the obvious thing, you know, when you compare HOLEP to TURP is that the retreatment rates. I think HOLEP is superior in retreatment rates. It's about, I think, 1 to 2% at 10 years, whereas TURP, the retreatment rate is between 8 and 10%. So that's important to take note. The other thing is HOLEP is also superior compared to TURP in terms of their Qmax as well. So that's the two obvious differences between HOLEP and TURP. Could you go back to the initial, just to the initial case that you did, that the patient scenario?
Yeah.
So 68-year-old, 80-gram prostate. Yeah, so you're sitting on the cusp there between quite big and so it's good. PSA 4 on tamsulosin finasteride for 18 months. The thing that I want to mention here is that you know, you want to see this patient in your dedicated one-stop LUTS clinic in an ideal world, and you know, you want to have an engaging consultation with the patient. The important thing to note here is that he's on finasteride for 18 months and his PSA is still 4. So it's important you carry out digital rectal examination, rule out prostate cancer. So that will be my first thing for this gentleman. I think, you know, he may need an MRI plus minus biopsy. What are the effects of finasteride on the prostate? Oh, we can't engage this. You have to type. Okay. And the important thing here again is that there's a number of things that finasteride does for the prostate. It doesn't, not only does it reduce the volume of the prostate by 30% at 6 months, it increases the flow rate by about 10%, improves symptom scores by 20 to 30%. It reduces the risk of retention by 50%. Example, the MTOPS trial, reduces the risk of BPH progression. It decreases the total PSA by 50% at 6 months. And the other function of finasteride, it can stop bleeding from the prostate. So it's important to bear those things in mind. This finasteride does have a number of. So yeah, so for this gentleman, I think the first thing is just to do DRE for him. And the other interesting thing that you mentioned here is enjoy a satisfactory sex life with his partner. So, you know, already you look at this and you start to explore the minimally invasive treatment options. You know, he may want to preserve his retrograde ejaculation. He may want to, you know, obviously preserve his erections as well. So you need to have a close think about that and really counsel him about the different treatment strategies out there. According to EU guidelines, the procedure that will avoid this will be a Urolift procedure, and that's licensed for prostates less than 70 cc's. But more recently, in the NICE guidelines, we can Urolift is indicated for prostates less than 100. So it's just something to bear in mind. But no, thank you. I'll interject as needed.
Sure. Dr. Salman Al-Qadir, you have any experience with lasers for prostate surgery? Any inputs from your side?
Well, thank you very much. I think most of the things you have covered very well. I just wanted to point out, like the previous speaker did, that this gentleman has been on finasteride for 18 months and has a PSA of 4. And as he very rightly mentioned that both finasteride and dutasteride over a period of 6 months reduce the PSA by 50%. So you need to double the current PSA to get the actual PSA, which in this case would turn out to be 8. And 8 is the level where you would want to explore them for a possibility of cancer prostate. So I think having a biopsy and an MRI would be certainly be in place. As for your question regarding lasers, yes, I do have some experience with laser, but my experience with laser is with the vaporization, not with the enucleation. I find the enucleation a little bit more troublesome. So we vaporize, and as you mentioned, the results are pretty good. But yes, there is always a reoperation rate, and the hemostatic advantage of laser is always there. So I think you have covered most of the things, and we need to move on.
Okay, thank you very much. Yes, I'm very happy with both the panelists picking out the importance of finasteride and need to double the PSA. So these patients will have an MRI. If the MRI shows any suspiciousness, we need to make sure we are ruling out the prostate cancer. The main reason is some modality treatment, say for example, holmium enucleation. If it is done with the prostate cancer in the background, then if the patient had a cancer in the follow-up, surgical modality like radical prostatectomy will be very difficult. Even for TURP, if a patient develops prostate cancer in the follow-up in the future years, it's very difficult compared to a naive prostate gland undergoing radical prostatectomy. So it's very important to make sure patient has no prostate cancer before proceeding for any benign involvements. Now, For some of the trainees, the topics which we are going to discuss now will be just only studied in the books and you may not have come across in your real life practice, but it's nice to know these things, what is happening in the rest of the world. And I'm very sure in the future years, this will be available in your country for you to learn and also to practice. So even though it's very theoretical, these questions of the newer modalities will be asked quite in the end of the scenario. So if you do well, that's like few minutes before the exam is going to award you the marks, you will really score very good marks. So let us cover the newer scenarios also. If you take, for example, a FRCS exam, that may be a complete scenario only on the newer modalities itself, because Resume, Aquablation, Urolift are all available in UK and we are practicing it in quite widespread practice. Starting with Resume, it works by the principle of convective water vapor therapy. It's very important. The key word is convective water vapor. The water or the heat can be transmitted by convection, conduction, and radiation. Radiation and conduction are very poor methods of heat conduction. It can cause significant necrosis and tissue damage. While convection, the advantage is there is not much necrosis. It's more of apoptosis and tissue absorption. And also the convective water vapor therapy will not cross tissue plane. So if you inject the water vapor in the transition zone, which is the predominant BPH zone, it will not cross the peripheral zone. And that's why the people who perform Resume claim that the chances of extra prostatic nerve injuries are much less. So try to remember the word convective water vapor therapy. It is a direct delivery by a needle. I think regarding the pictures, most of you may have seen some pictures or videos. Possibly when Professor Athar is happy, maybe next time we can do a full 1 hour session on the newer technology alone. At the time I can show the videos, short clips, like 5 minutes each of every procedure, which may be more understanding. But since this program is more constructed to help the exam going people, let us just look into the basics and understand the mechanism of the newer devices. It's a thin needle which is deployed. The needle tip has got 12 holes. And once you deploy the needle will eject the water vapor at 103 degrees Celsius for 9 seconds. After that, the needle will retract automatically. Approximately every needle will produce an area of 1 centimeter spherical apoptotic lesion. So you need to plan your injections so that they are not so close to each other. If you inject 2 injections too close, the vapor which you injected in one will leak through the hole in the other. If it is nicely planned, it's a nice surgery. It is getting a lot of backup, 5-year data and long-term data are on the way. There is a 4-year randomized controlled trial between the Resume arm, which showed excellent improvement in IPSS, quality of life, Qmax, and the need for surgical treatment is around 4.4%, which is not bad when you compare to TURP. So NICE guidelines released in June 2020 supporting Resume, but it should be considered as a part of the clinical trial and everything should be documented appropriately. The gland accepted is between 30 to 80 cc. Even for Urolift, now the gland is 30 to 80 cc. The May 2021 new NICE guidelines has reduced the Urolift gland permissibility from 100 to 80, but most of us still do Urolift up to 100 cc, 110 cc with relatively good outcome. But if the gland is really less than 80 cc, the outcome is very appreciable. Aquablation. This works by the principle of image-guided robotic water jet ablation. So there is a patient will be in anesthesia. There will be a transrectal linear ultrasound probe with which you can map the prostate length, breadth, width. And once you switch on the machine, the robot will inject the water jet from the veru to the bladder neck. Sometimes you need to run 2 times or 3 times to get an appropriate ablation. You can see the ablation real time by using the ultrasound machine. And the one disadvantage is you need to do post aquablation, cystoscopy, and you may have to use sometime laser or a monopolar or bipolar TURP rolly ball to get appropriate hemostasis. If appropriate hemostasis is done, the outcome is relatively good. Patient may need catheter just for a day or two, and they have very good improvement. And aquablation had water 1 and water 2 study. Water 1 was started in Nadia, India, and then they had a multi-center involvement and showing good improvement. Water 2, they have recruited larger glands, 80 to 150 ml, and this is the advantage of the aquablation. The whole setup, setting up the scan, setting up the patient, volume, acquisition, etc. will take around like 20-30 minutes based upon your experience, but the procedure as such will take only 3 to 4 minutes. Not full-fledged available in the Western countries. It is still done under trial. NICE guidelines released in 2018 is supporting aquablation, but it should be practiced with appropriate audit and follow-up. Prostatic artery embolization, a huge trial, rope trial was done based in UK. A lot of people were recruited. The only problem is it requires a good relationship of an intervention radiologist with a urologist. Already, especially in Western countries, we have lost a good amount of interventional procedures like pre-PCNL renal access or nephrostomy placement to interventional radiologists. And even prostate biopsies were done regularly by the intervention radiologist when compared to the Asian countries. So we don't want to really lose benign prostate also to them. And it's suitable for a very selective group of patients. Say, for example, if the patient had a previous TURP with regrowth of prostate presenting with bleeding, patient is not fit for anesthesia, and patient is on anticoagulant where you are not quite happy in taking the patient back to TURP. But even in that situation, if you have a laser, that may be a better situation, better choice than the PAE. PAE involves very heavy radiation of CT scans because you need to get a good volumetric CT scan with the angiogram phase. You need to know the vascular anatomy, and if the vascular anatomy shows that patient has significant atherosclerosis, the radiologist can't pass the embolization catheter proximal enough to close the glands and create the embolization outcome. The rope study completed in 2018 showed good improvement in quality of life, and the improvements were slightly greater than the TURP arm. I've got the references in the screen. Once you get the recordings, possibly you can use these references in your exam. Both EAU guidelines 2021 and NICE guidelines 2018 has supported this, but it has to be done in a very standard arrangements of audit and clinical governance. We can't offer that quite regularly. Prostatic urethral lift is much more widely practiced and the acceptance is slightly better. In my trust, we are doing it. We are quite happy and proud with that. We have plenty of patients with very good outcome, and we are training also people who are attending us, and we even travel to other countries to train the other surgeons. Can be done under general anesthesia or local anesthesia. Maybe in the starting, general anesthesia is a good choice. Once you get the knack of applying the clip at the correct place where you want, then you can do under local anesthesia. For local anesthesia, maybe 1 gram paracetamol 30 minutes before starting the procedure. And we tend to use a cold lignocaine, and cold lignocaine has a better mucosal absorption, and the coldness itself can cause a bit of a urethral anesthesia. And the implants can be placed based upon the size of the gland. Many patients require only 2 implants left and right. Some patients may need even up to 4 implants. If there is a median lobe, there may be a need for 1 separate implant for the median lobe alone. It started with a lift study. It's a multi-institute, again, randomized controlled trial with a procedure of urolift and also a sham treatment where the patient had the same cystoscope without any lift implant placement. Good improvement as usual with IPSS, quality of life, and BPH2 and Qmax indexes. All these studies, if you see, always there is a good improvement of the results. Because if there is no improvement in the results, number one, we may not be even discussing it now, and we may not be educating people on the energy source and spreading the word. So most of them will have very good results. The only thing is patient selection. As long as we have a good patient selection, the patients will have excellent result. Can I just again invite Mr. Khan? What is your view on this minimally invasive therapies?
Yeah, I mean, fantastic overview, Anand. I think you've covered most things there. I'm pro minimally invasive for the right patient, but the interesting point that I would like to mention is just that we're living in a Montgomery era nowadays, and I think it's important that these patients, and I want to stress the importance, and you need to mention this in your exam as well, that there are a number of treatment strategies for BPH. You need to counsel the patient for all the options out there for them. Even if it's a particular management that you do not offer in your hospital, they still need to be made aware that there is UroLift as an option that will preserve their retrograde ejaculation, etc. Antegrade ejaculation. And even if you don't offer it to them and another hospital does, it's important that they are counseled for all the treatment options out there. Because in this day and age, if a patient has a TURP, because that's all you do, and they come back and they have a problem, you have no legs to stand on, I'm afraid. So I think it's important that there are a number of treatment strategies. BPH is becoming very much a tailored approach for the patient. No one size fits all. So I think that's the important point I'd like to mention. But otherwise, Anand, that's a very comprehensive review. Well done.
Yeah, thank you. Dr. Salman El-Hadid, what is your view on these new technologies? Dr. Salman?
Yes. Can you hear me now?
Yes, we can hear you.
Yeah, sure. Thank you very much. You have done a wonderful review of the minimally invasive procedures. And I believe you are 100% correct when you said that these new modalities are currently not available in Pakistan. We don't have the UroLift, the RESM, the PAE, or the aquablation. But I think from the residents' point of view who are preparing for the exam, it is absolutely necessary that they have a basic idea of what these non or minimally invasive techniques are all about. Because as you very rightly said, it's important that we do counsel our patients, give them the options, and some of them may be wanting to go for these minimally invasive procedures, even if they have to go outside Pakistan, and that's their own choice. One thing I would like to point out is a word of caution for all our residents who are taking history and preparing their patients for surgery. We tend to be a little bit less involved when taking the sexual history. I think this is something that we really need to go into, especially for those patients who are going in for surgery. And you never know, one of these patients may come back to you and have a major issue after having retrograde ejaculation following TURP, or having altered erection following TURP. So it's important that we counsel all our patients. We do take a proper history and counsel our patients that whatever surgical procedures we are going to be doing, what effect that would have on their sexual performance in the post-op period, so that the patient is well aware of what he is undergoing. And if they have any reservations or any strong objections to it, then they should be offered the minimally invasive procedures and told that they can go wherever they want to for these minimally invasive procedures. Thank you.
Absolutely. I entirely agree with both of you. As Mr. Khan said, it's very important that consent should be very comprehensive. Even if you are not offering a surgery, don't feel shy in explaining the other options. But of course, you can easily sell what energy source you have, and you can still hold the patient without losing the patient to your colleagues practicing nearby. And as Dr. El-Hadid said, it's very important that you should know the basics of these energy sources, so that when the opportunity comes, it's easy to understand and know the strong evidence behind that. I have a few more slides to complete.
Sorry, the other final point that I wanted to mention was the obviously when it comes down to consent, but it's the longevity of these procedures is the other thing. Particularly with UroLift and Resume, evidence is around 4 to 5 years. And again, they may have symptomatic relief for a few years only, whereas TURP, HOLEP, the longevity of the procedures are a lot longer. There's evidence for 15, 20 years plus. So that's another important thing to bear in mind when counseling the patients.
Yes, absolutely. If the patient selection is done with the, for example, NICE guidelines criteria of 30 to 80 ml, and if the techniques are good, hopefully they should have a little bit more longer effect of the surgery, but we don't have the evidence behind that because
absolutely,
because the evidence is released only 5 years in 2017. So hopefully by next year, we should get the 10 years data for Eurolift. But the time will tell about the longevity. And hopefully, I think somehow they will try to establish that the retreatment rate is almost closer to TURP or slightly worse than TURP. In that case, also it's equally acceptable because of the erection and ejaculation advantages. So for the students who want to quote the evidences, BPH6 study is a good evidence for prostatic urethral lift, and I've tried to place a summary of the evidences. There is a Cochrane review happened in May 2019, and MedLift study is the study specifically looked into the use of Urolift for the patients with middle lobe. Unfortunately, in the initial publications, they have removed the patients with middle lobe. And so this study is a very landmark study for making the Urolift practitioners to use the Urolift for the middle lobe also. Slightly different technique, but it's still working.
The other indication or the other place where Urolift has a role is even prior to medical management. I think there are patients, and when you counsel them for tamsulosin that can cause retrograde ejaculation and erectile dysfunction with finasteride, there are a small portion of patients who off the cuff are not keen to start medical management. So there is a small select group of patients whereby they can have Urolift as a procedure before even medical management. So I think that's an important step to, the counseling part, or particularly as part of your exam, that you'll see these patients, you'll counsel them, and even from the medication, you must counsel them about the side effects of medication and what their limitations are. And a select group of patients who aren't willing to accept those side effects, Urolift can be given or can be offered to them upfront. Thanks.
Yeah, this is one of the area where, for example, especially in patients with some neurological problems like Parkinson's disease or Alzheimer's disease or dementia, if you start them with, say, tamsulosin or finasteride, especially the anticholinergics, it can cause significant anticholinergic burden and can result in further worsening of the neurology-related side effects. And patients who wants to preserve the erection and ejaculation, and there's nothing wrong in trying them with tamsulosin to see whether the problems of erection or ejaculation happens with them or not, because not everyone will have erection and ejaculation problem. And these new procedures are quite costly. We got a question from Jamshid Nawaz. These patients should be given option to the young patients who want to preserve the fertility. Yeah, that's what exactly we are discussing. Yeah, we have to give this as an option to the younger patients who sometimes maybe even willing to have one more child. Continuing with the evidence for the Urolift, Pulsar study completed in 2020 and published in all the international meetings, AUA, PAUS, EAU, in 2021. It shows the safety of the Urolift in patients who had retention. This is mainly for acute retention, not for the chronic retention. And there is 67% chances that the patient may be catheter free. Again, whether the longevity of the procedure will be good, we don't know. The common complications, like any procedures, like any cystoscopic intervention, hematuria, dysuria, pelvic pain, urgency, transient incontinence, and UTI. These side effects also can be very well managed if the implants were placed as minimum as possible and in the correct placement. Intraprostatic injections, this is the one which is least favored by anyone. Simple reason, it don't work. But just for the completion of the syllabus, botulinum toxin A, there are some medicines like fexapodine trifolate or the investigational treatment like PRX302 are available. It should cause apoptosis-induced atrophy of the prostate. Real life, not much improvement, not much strong studies. And EAU 2021 clearly mentioned do not offer intraprostatic botulinum toxin injection for treatment of male LUTS. The reason I brought this slide is, by chance, if your examiner is quite a well-read man and knowing everything, and if you are very good with resume, Urolift, everything, if he keeps on asking you, is there any other modalities which you are aware of, keeping this intraprostatic injection in the mind, I don't want you guys to get the bad side of it. That's why that is mentioned. ITIN is an emerging treatment. It is still in a very early phase. The NICE guidelines has released a kind of a model of how we can do ITIN in a experimental and also in a clinical governance based setup. It has 3 strings, which when applied will cause like a Mormere type of Turner-Warwick type of bladder neck incision, like a BNI, 3 areas. Mercedes-Benz sign, and for application, you need a patient to be under significant sedation, if not GA, but removal can be done when the patient is awake. The period when the patient has this implant for 5 to 7 days, frankly, that's very horrible. Complaints of significant dysuria, patient needs to pass urine against the metal. So that is the main disadvantage of ITIN, but they have slightly modified it. The companies, the big companies have bought these small equipments and they are slowly modifying it. And but there is no strong evidence for ITIN yet. Allium is a type of walled stent. You can use Allium even for the ureter, malignant ureteric strictures, available in various sizes. We can use it for VUJ or PUJ alone or the whole ureter, and this can be used for the urethra also. Again, stents may be the last choice, if at all, if you want to do. Any benign prostate enlargement treatment is not complete without discussing the minimally invasive simple prostatectomy, whether it's open prostate or whether it's robotic assisted prostate. These are now extensively practiced. You can see the seminars with benign prostatic hyperplasia. There will be always a robotic surgeon to complete to say that it is possible to do transvesical simple prostatectomy, almost mimicking the open prostatectomy techniques. Again, it's just a different equipment. The treatment, everything is same principles of open prostatectomy, which is very well established, as we all know. There is one more question in the chat. Oh, thank you, sir. Very good. I'm stopping the screen sharing, and we have excellent panel here with a very wide experience on various energy sources. And any concluding remarks, Mr. Khan?
No, that was fantastic. Very good presentation. You covered all the treatment strategies there, including stents and things. So, no, very well done. It's really good.
Thank you. Salman, you have anything to add?
No, thank you very much. I think all the topics, in fact, the new invasive, the minimally invasive things have also been covered very well. And I hope the audience has grasped the essence of the talk and would be ready for the exams now.
Thank you very much. That's very kind of both of you. Thank you for both of you joining us. And thank you very much for Professor Athar to giving us this option for 2 consecutive years. We hope we will have the presence for the future years. My request is, if the duration is given a little bit longer, we can prepare much more in detailed presentations. Mr. Khan is my colleague. We do Eurolift. And so, for example, Eurolift alone, I can personally talk for 2 hours or 3 hours, but it's not necessary for the exam purpose. But if we can even have it on a different 2 days, so that we can show some short videos of these newer technologies, so that the residents are not looking into substandard YouTube videos and learning something of their own. We can show the exact proper videos with proper techniques. And I'm very sure the young residents, when they are practicing in the age of at least like 40s and 50s, they will have access to all these technologies.
Thank you very much, Ananda. This is wonderful, and really will appreciate your offer. Definitely will engage you, Mr. Khan, Mr. Sami, over the next few meetings that we're probably organizing. And we probably can have a dedicated session on BPH, in which probably these newer options, and if you're practically involved in it, that would be wonderful to see your own experience. I mean,
Professor Athar, is there a role for Eurolift and these minimally invasive options in Pakistan at one time soon, or?
Cost is a major factor, and okay. But I really like your comment about using these minimally invasive options, Mr. Khan, about for patients who either do not tolerate alpha blockers or other
Absolutely,
medical treatment,
Yeah.
or they have significant side effects.
Yeah.
So, I mean, these minimally invasive options, at least they are good for a short period of time. The data is indicating that. And they are often done under little anesthesia. So they can be even done under pseudo-analgesia, some of these at least.
I mean, the Anand, I'd just like to mention, he's a UK leader on Urolift. He's trained a number of surgeons in the UK. He's trained a number of surgeons internationally as well. So, you know, I think hopefully one day not too far, but, you know, I'm sure Anand and I would be happy to visit Karachi and show you guys a bit more about Urolift and things. And, you know, obviously with what's happening at the moment, when in a couple of years' time, but I think the future is going that way. I think you do need to have a procedure that preserves antegrade ejaculation in your armamentarium. I think, you know, there's, you know, I think that patients, they do want it. And I think you do need to explore those questions with the patient. And I'm sure there'll be a huge takeoff. I mean, there's a huge takeoff here in the UK on patients wanting Urolift. Even if they're 60s and their 70s, they may want it for 5 or 6 years to, you know, before they undergo a treatment that will, you know, potentially give them some complications. But it's something that, you know, you should try to aim to offer in the next few years. And if so, I think Anand is the man to come out and visit you and perhaps show you a few cases.
Wonderful. I mean, we'd love to have you guys coming over to Karachi. I hope that you don't need a approval from English Cricket Board. So thank you very much for this wonderful session on BPH. And we know that prostate is in the heart of urology. And since we always torment the heart, we tormented it in all possible ways, from microwave thermotherapy to high frequency ultrasound to alcohol to everything. But TURP is still the major player, with HOLAP very closely competing. So thank you very much, Ananda, Fahad, and Salman for this wonderful session. And that could be the best possible way to end this Karachi Urology Week of 2021. So have a good evening and enjoy your weekend. So
thank you.
Bye-bye.
Thank you.
Thank you very much, everyone. Thank you for a lovely session. Thank you.
Bye. Thank you, Salman. Thank you, Fahad. Thank you, Professor.
Thank you.
Thank you.